We'll kick off with Dr. Mehra presenting a few of the Perio cases. Then Dr. Josh have a quick presentation on IV sedation and thirds. Um, we have specialist introductions. Dr. Gilbert is going through bone graft and collagen plug importance. And we have new docs giving some introduction, and we'll open the floor up for discussion. Dr. Mehra?
Hi, how are you guys?
Good, thank you. How are you?
Good. Um, I'm going to share my screen. I haven't done a Zoom presentation in a while. Give me one second.
No problem.
Um, it's sorry, it's showing. Okay, I'm just gonna share two at once. Um, Sorry, it's asking me to give it permission to share my screen.
Okay.
Okay.
Think
Is
Ishan
it
probably went.
working? No.
No, we can't see it yet.
Okay, let's try now.
Yeah, it's coming up. Yeah.
Okay, perfect. Um, you can see the whole thing, right?
Yes, we can. We
Okay,
can see your
perfect.
slides, and we've got advanced periodontal procedures.
Okay, good. So you can see how many I'm going to skip to be able to do this on time. Okay, so you guys let me know. I'm going to show a little bit of literature, not too much literature, and just kind of when to refer for a few different types of cases, and then I'll jump over to a different PowerPoint, which is just some cases I've done, just because I know a lot of you haven't worked with me yet, so it's just kind of, I guess, showcasing my abilities a little bit. So I'm going to skip over like how to diagnose, how to talk to patients about periodontal disease. That's something if you guys have any questions, you can ask me later. Um, so the first case that I'm going to be talking about is going to be osseous surgery. So basically the treatment sequence, we always start osseous surgery with SRPs. No matter if it's a cash patient, insurance patient, everyone's going to start with SRPs because one, SRPs help me kind of during the surgery if I have to do it. It takes away some of the time that it takes to remove any kind of supracrestal uh, calculus and any other kind of debris. And two, because if the patient has bad hygiene, they're not a good candidate for osseous surgery. So it allows us to give them some kind of time to improve their hygiene. And then three, because, give me one second. Three, because it takes about 4 weeks for the periodontal pathogens to come back. So that's why we wait 4 weeks after SRPs to reevaluate. So again, here, this is the plaque control suprasubgingival scaling. So this is all included in the SRPs. There's a study done by Warhog that shows that the pocket, sorry, it's a little bit graphic for some of you who don't normally see patients. So probing depths that are less than 3 or 3 to 5 millimeters are really what the scalers can get from the hygiene. And anything over 5 is typically where I see where a lot of those cases don't resolve after SRPs, and that's when you refer them over to me to do any kind of osseous treatment, regenerative therapy, anything like that. So kind of touched on this, the limitations. Again, if you guys have questions about this stuff, I just want to leave some time for showing the cases. Okay.
Dr. Merrick, can I ask maybe a
Yeah.
basic question? What
Yeah.
exactly is osseous surgery?
Yeah, okay, great question, and I'm going to show you actually right now.
Awesome.
Um, yeah, so let me know after I go through that. Um, okay, so SRPs are done. We see a patient for reevaluation after 4 weeks. And that kind of shows us how effective the SRPs were, how the patient's hygiene is, if there's any periodontal bacteria that has come back and we still have pockets remaining. So, what osteosurgery is this is a case over here. We're focusing on the lower left. Um, can you see my mouse at all?
Yes. Yep.
Okay, perfect. So we can see here we have some sixes, we have some fives, five, sixes. This tooth over here, 17, is going to be extracted. So this is the initial perio exam. Actually, not the initial perio exam. This is 4 weeks after SRPs. So we still have pockets present. Bless you. Um,
Oh, I'm
okay.
God.
So here are the radiographs for the left side. We can just focus over here. What I'm looking at is the bone levels. So here, and sometimes we can also see cratering. On this case, there's not such a great example. But if you look at the anteriors, you can kind of see that the bone is kind of scooped a little bit. So what that means is that that's a plaque trap. So when a plaque is sitting for a long time, what it does is it turns into calculus and the bone starts to break down. So osteosurgery is going to eliminate that bacteria that's in the bone, any remnant calculus and plaque buildup that's on the teeth, with the flap open. So the whole purpose of osteosurgery is it's kind of like a deep cleaning on steroids is how I describe it to patients, because I'm going to be opening up the flaps and I'm going to be able to see where the buildup is and can eliminate everything that's causing the pockets to remain and keeping periodontal disease in the mouth. Okay, so this is the initial presentation. So we can see that we have the gingiva, a little bit of interproximal attachment loss. We have some open contacts. Can see a little bit of plaque, um, and a little bit of redness in the interproximal areas. So this is the lingual, same thing. The big thing here that I'm seeing are these rolled margins that are a little bit red. This is where we get the bleeding. Um, and this is number 17, which will be removed as well. So this is the incision. So with the molars, typically what I'll do is if there is enough attached tissue, so here we can see there is, I double scallop the gingiva. So this is a double scallop, you can see with my mouse, and then this is a single scallop. So this basically, I'm eliminating that swollen gingiva and that distance that goes between the bone and the top of the gingival margin. So that's going to allow the gingiva after the surgery to sit directly on top of the bone and allow for ease of cleanliness for the patient. And same thing here, you can see a little bit of the double scallop. Um, and we always extend a little bit further than where the surgery needs. So this is the bone. Okay, so we know from, dental school and our training that positive architecture is when you have bone higher in the interproximal areas and in the furcation. So this patient has reverse architecture. So what that means is that it's the inverse of what we expect. So in the interproximals, the bone is actually going down instead of up. So these are the craters that I was alluding to before. So this is where we get plaque trapped in the sites and where calculus can build up and where we get that bacteria trapped. Same thing here. This side isn't as bad, but we have a little bit more of flattened architecture. And then over here, we have some negative architecture. Okay, so osteosurgery, the thing that I didn't mention is that in addition to cleaning as best as we can, I also reshape the bone. So what that means is anywhere that there was reverse architecture, what we try to do is flatten it out. So obviously, if I eliminated bone too much over here to give positive architecture, the patient's going to have no bone left. So this is a compromised case over here, but we can see that now we have a little bit more proper scalloping, especially in this premolar area and in this number 19 area. And same thing on the lingual. Like I said before, this didn't require too much, but what I did do is take in all this bone that the flap was sitting on, because this exostosis, a lot of times that's on the lingual, as well as a little bit on the buccal here where you can see it's kind of popping out. That is where we get some food trapped as well, and plaque. So this is the before on the left, and on the right is the after. So we can kind of see, this was a case from residency, so don't judge me too hard, but this was a case where we had some negative architecture, some flattened, and where we had to kind of try to balance it out as best as we could for the patient to be able to clean. And so that, we're not getting as much stuff trapped in there. Same thing, this is the left picture is the before, right is the after. So you can see all this bone I took in, and that'll allow the flap to sit a lot easier and the gingiva to sit closer to the teeth. So this is some of the suturing. So a lot of you will see these patients for me a week after. Sometimes these sutures are annoying to remove depending on how I do it, but what we can do is you snip each line that you see, and then you can pull out each individual thread, because this is one continuous suture. And so this is the before on top, and then 7 months post-op. So we can see now the patient is able to keep the area a lot cleaner, have a little bit of buildup right here, but that's supracrestal. The gingiva is nice and pink. It's healthy, and the teeth look a lot cleaner and plaque-free. And sorry, I meant to say that yeah, the before and after, as you can see, the top is the baseline. Okay. And so pockets, we've eliminated pretty much all the pockets. There's one 5 mm pocket over here now, but there was no bleeding on probing. So typically bleeding is our marker. So if there's a 5 mm pocket, but the patient has great hygiene, they used to have a 7 mm pocket, there's no bleeding anymore, that means that they have a good result. And typically we do expect about a 2 mm improvement in those sites, as well as improvement in hygiene and allowing the patients to come for or making sure that they're coming for their maintenances and all their cleanings and their exams, to keep up with it. Um, so here's a quick study for why they need to get their perio maintenances regularly. So patients who did not get maintenances regularly after treatment lost 0.36 teeth per year, as opposed to 0.11 teeth per year when they did. So the value of maintaining the patient after is just as important as their oral hygiene instructions and everything before. Um, So yeah, perio maintenances, the goals are to prevent recurrence for these periodontal patients. And we know that periodontal disease can't necessarily be eliminated, but it can be controlled. So seeing them regularly is very, very important. And we want to always maintain the patient's current dentition and save teeth whenever we can, and catch things early. So this perio maintenance, usually I'll say the first maintenance is going to be 3 months after osseous surgery. But sometimes, patients, they won't come back as quickly for treatment. So sometimes I'll let them get a cleaning in between, just because it makes the surgery a lot easier, not only for the calculus that's present, but also it eliminates some of the swelling and edema that's present when there's plaque present. So it kind of just helps me during the surgery. Any questions on the osseous so far? This was the case.
Yeah, it makes a lot of sense. So I just want to make sure that we all have the right game plan. SRPs, re-eval in 4 weeks, if pocket depths are greater than 5, can we diagnose the osseous, or do we send them for a consult with you?
We'll
Uh,
still do a consult, but to be honest, patients are way more accepting of therapy when they've heard it from, the hygienist, the general dentist, and then by the time I see them, they're kind of like ready to go. Like they've heard it so many times, and they don't really think it's a scam because a lot of them
yeah.
won't really understand what they're being referred for. So as long as you guys kind of know how to describe it to patients, they're just way more willing and they understand the importance of it before. And
Yeah,
I
that makes sense. I think when we describe it, we have to make sure we're not necessarily talking about laying a flap and being that descriptive. I think we have to say that the specialist can approach and see areas that we normally cannot. I think we have to use some more
yeah.
layman terms.
And if they start with like 7 millimeter pockets, SRPs probably aren't eliminating those. So just kind of letting them know that they might need further therapy later on, they'll appreciate it more because they've heard it. Like they kind of already know.
This is Shalab Puri. I had a question about a patient coming in with 4, 5, 6 millimeter pockets. We do SRPs. Can you talk a little bit about adjunct treatment like arrestins or even laser therapy? What role does it have before osseous surgery?
So to be very honest with you, there's a lot of research that goes both ways on both therapies. Arrestin is shown to it doesn't hurt, but it doesn't necessarily help enough to eliminate osteosurgery. It might hold the patient off for a little while and decrease those pockets temporarily, but unless we keep continuously applying the Arrestin and we're eliminating all that plaque, it's not going to do as much as the actual surgical procedure itself. And then laser therapy, I've seen a lot of mixed things. Same thing. It helps, but we do want to be careful with laser therapy that we're not eliminating too much of the soft tissue. Because I've seen some of the damage being done when it's like kind of aggressive laser therapy. I'm not saying it doesn't help. It definitely can help. But if the laser therapy isn't working either, same thing, we may have to do osteosurgery, but can definitely see how the patients respond to that. But sometimes what it takes is to just open up the flap and actually remove the calculus that we see that the laser also can't necessarily see because it's more tactile.
And what do you think about the Perio trays where, they make those periodontal trays with hydrogen peroxide in, is that a good maintenance therapy, a good.
How often are we doing that?
So our hygienist, basically, he does the SRPs coming back every 3 months for a maintenance therapy, and he sees scattered pockets still bleeding
Hmm.
from probing. Patient hygiene not necessarily up to par. Um,
Yeah.
so he would recommend, or I would tell him to, talk to the patient about the periodontal trays with that hydrogen peroxide medication. And if the patient is compliant, it does show improvement over a period of time. So,
Yeah, so as long as they use that, then absolutely. Um, but same thing, kind of like when we prescribe antibiotics for an infection, like an endo infection or anything like that, we're not necessarily eliminating the problem. So if the pockets are still persisting, even after that peroxide therapy, then definitely send them over. Um, and we can give it some time, but yeah, if the patient's hygiene isn't great, then that's a good option for while they, if they're motivated enough to improve.
okay. So can they have this periodontal trays and all after osseous surgery? Would that be a good?
I I would wait about 3 months after,
Uh-huh.
because what we want to see is how the body responds to it. And because we're opening a flap, so I don't really want the peroxide to kind of sit on the bone so closely. So I would definitely wait. until the following maintenance before doing that. I wouldn't do it within a month or anything.
Okay,
Did that answer your question a little bit?
sure.
Okay, perfect. Okay, so the next two cases, I'll run over these a little bit quicker, but it's going to be soft tissue augmentation. So there's two types of gum grafts, basically. A connective tissue graft, a CTG, and a free gingival graft, an FGG. So there's different uses for both. And I get a lot of questions from my GPs about this. So I'll go over these. I have a lot of other cases. Some of these techniques I don't really use as much anymore. But it's kind of just to show you what these graphs can do for the patient. So this classification, there's class 1, 2, 3, and 4. I won't go into so much detail, but classes 3 and 4 is when you have interproximal attachment loss. So I'll get some referrals for patients where, the bone level interproximally is almost at the apex, or not at the apex, but the apical third. I can't really get much tissue coverage with this. So the way I describe it to patients is the interproximal bone kind of acts as tent poles, and the gums kind of act like the tent that's sitting on top. So the lower the tent poles are, the lower the support is. So if there's interproximal attachment loss, I will never be able to get 100% root coverage. Now, if there's no interproximal attachment loss, a lot of times we can get 100% coverage, but I'll usually tell the patients to expect about 80%, because a lot of times their traumatic toothbrushing goes beyond the CEJ and is kind of still within the enamel, and that can't be covered. So that's something that is helpful for the GPs to kind of set those expectations as well. So this is another case I did in residency. Um, so I believe we treated more teeth 11 and 12, not so much number 10. But this patient has really nice thick tissue, and they have a thick band of keratinized tissue. So right here, before we can see the unattached mucosa up top. So the goal in general, especially in aesthetic areas, is to, yes, cover the gum recession, but for a lot of patients that don't have this thick band of keratinized tissue, it's to increase that width. Um, and I'll always take a mirror and I'll show patients kind of the difference between the attached and the unattached mucosa. And I'll kind of show them that if this unattached mucosa is kind of coming up onto the tooth, it's just going to keep the plaque present there. And if the patient has thin gums, their results are typically worse. Not bad, but they have less predictable results than patients like this that have thick gingiva in the first place. So this is a different technique. I use a similar technique and I use another technique as well, but you'll see this one has an incision over here in the frenum. And you'll see here there are these composites that are in between the teeth. These are going to be meant to hold the sutures in place. I don't do this anymore. It's really, really a big pain to take off these composites. So I just do most of this with my suturing. So what I do here is I take an instrument through this access point and I'll loosen all the muscle tissue and all the papillas. I'll lift off the bone until all these areas are stretchy and can be advanced into where the original margins should have been in the first place with these teeth. And another thing I forgot to mention is for these patients, if they are still brushing too hard, I always tell them that, you're not getting rid of the cause. So electric toothbrush with a pressure sensor is something that I always let them know that that habit has to stop before, until this happens again. So anyway, I'm going to lift these. I do have a video somewhere. I couldn't find it, but all the papillas are going to come sit higher as well as all the gingiva. I Okay, so this tissue came from the roof of the mouth. I'll have a picture that'll come up in a little while. But this is connective tissue. It's the underlying layer of the palate, the hard palate. So the top layer is what we take for a free gingival graft. The underlying layer is the connective tissue graft. This is used for more aesthetic cases. So now this is going to be tucked in under the tissue. And so this next picture here will show that. So these blue sutures that you see are holding the tissue advanced. So you can see here that these gingival margins are now sitting higher up on the teeth. And again, this is in residency, so please ignore some of those folds. And the connective tissue graft is sutured. There's one suture here and there's one that we can't see, but it's sutured underneath the gum. So these are all resorbable sutures that are with the graft, and then these have to be pulled out later, these blue sutures. And that incision was also closed over here. And so this is the palate. This technique I don't do as much anymore. So usually what you'll see is kind of a rectangular shape. And I'll put collagen plug and this will be sutured. There will always be sutures on the palate. This I used a little bit of glue because this patient was bleeding quite a bit. So we used some glue to help just get some hemostasis in the area. So this is the 3-week post-op. The patient hasn't really been brushing here. So what I'll tell patients is at the 2-week mark, that's when you guys, the GPs, are going to take out the sutures for me. And at that appointment is when I remind them that they need to start brushing and flossing. So part of their post-op instructions is not to brush or floss the sites in which we did the surgery. And I'll show them again with the mirror. And I don't want them to pull on their lip. I don't want them to look in the mirror. I don't want them to do any of that. And so when you guys take out the sutures, it's really important to just remind them that they can now start brushing and flossing gently and eliminating all this plaque. Because all this plaque that sits here, this is what's going to push the tissue back. And also here we can see that the tissue is a lot thicker. So that's a good thing that helps act as a protectant layer and kind of as a band-aid. And the reason why the graft is placed under the tissue is because the patient's existing gingiva here is going to provide the graft blood supply and nourishment. And the two will basically merge into one. That takes about 10 days. So that's why I'll give the post-op usually 2 weeks, but 10 days is fine. So this is 2.5 months. So we can see now that little fold that I had shown is now blending in. Everything's going to blend in really nicely. This area here, so this is what I was saying with setting the patient's expectations. The gingiva is actually where it should be. This over here is from the patient brushing too hard. So now this is an enamel. And a lot of times there will be composites in the region, and I'll actually remove those. There's no way to get a fully closed class 5 recession. So that's why usually I'll remove all of it, if not most of it. But for a case like this, if the patient had a restoration, I would have left part of it here so that it wouldn't show and tried to smooth it out as best as I could. So this is the before and after, and this is with the 2.5-month follow-up. So any questions about the connective tissue graft? Okay, so the free gingival graft. So this is going to be, like I said, this case here, what I did was I made an incision and I took the tissue that's underlying. So it's kind of like an envelope. So now the patient's existing palatal tissue is now covering where we took the graft from. And for the next case, it's going to be taking the top layer. So these are some of the indications for the free gingival graft to increase that keratinized tissue that I was pointing out to you guys on the last case. This can be done around implants or teeth. It'll improve hygiene because of that increased keratinized tissue. Comfort for hygiene, so the tissue isn't coming up on the tooth constantly while they're trying to brush and keep it clean. It can be used, and I say this carefully to cover gingival recessions. It is not very predictable. And it's typically used on like the number 23, 24, 25, 26 region. But a lot of times, if they have recession in that area and I do the free gingival graft, I'll have to go in again to do a connective tissue graft to get more root coverage. And I'll kind of show you why. And the last most important one actually is to increase vestibular depth. So if a patient has any kind of prosthesis, if they're not getting implants and they're going to get some kind of partial denture, complete denture, and it's not staying on, a lot of times it's because they don't have enough attached keratinized tissue. They have too much of the of that mobile tissue. So again, this will improve hygiene and it'll allow the prosthesis to sit better. So this case that I did is actually going to be on an all-on X that was done a long time ago. And so here we can see this in between the implants. This is all the attached tissue over here. Now we can see where my mouse is coming down. All of this is the unattached mucosa. So this is what we can see is causing this plaque and calculus buildup within the implants. So this is where we want to increase that keratinized tissue. So it's going to kind of go in this region. And this back one over here does have a little bit more, so we didn't include that in there, I don't believe. But the minimum is usually 2 millimeters. So 2 millimeters is really that safety zone. Anything less, we recommend the FGG. So this, I'll show the palette later, but this is the top layer of the mucosa, and I've taken it out of the, sorry, of the hard palette, and I've shaped it already kind of outside of the mouth. And over here we can see we want it about 1 millimeter in thickness. If it's too thick, it won't get enough blood supply to this site. And it'll shrink a little bit more during healing since this one is going to be left exposed. So here's the implant, here's the other implant. So I've placed it kind of right at the margin where we didn't have that tissue, where we want to increase that attached tissue here. So I've sutured the graft in place. This one heals a little bit quicker because it's thinner than the other graft, the CTG. So this takes about 7 to 10 days. And some of the sutures will be resorbable, but most of them will be removed. I'll still do the post-op 2 weeks later if I can, but this one, if they come within a week and they really like are itching to get any of those sutures removed, I'll remove the loose ones. But if there's anything that looks like it's holding anything on, I'll leave it in place. Okay, so this is the palate. So same thing, this is going to be sutured. And this is typically where a lot of the bleeding will occur. The greater palatine artery sometimes can come through, but this is the top layer. So this is 1 week after the patient's prosthesis was already placed that day after the surgery. And these sutures were removed. So we can already kind of see down here, this is where we can see the graft has taken. This is the palate after 1 week. This is after 3 weeks. So now we can already see that we have a nice attached tissue. And what you'll notice here, so this is the 6-month follow-up. So this is a really, really nice result. And we can see the prosthesis is sitting nicely. The patient can reach and clean, and it's a little bit easier. But the big thing for this, and the reason why it's not used for aesthetic cases, is because it looks a lot more white and a lot more bulbous. Now, this is a case where it actually has blended in kind of nicely. But most cases, it's going to look different and it's going to feel different. And I will always show the patient pictures so that they're not really blindsided and they kind of know what to expect. So this is going to look a little different, like I was saying, but the results are really, really nice. And if you imagine if we had a partial denture or a complete denture, would not have been able to fit properly, and it's going to create a lot of pain for the patient. So now we have thicker tissue, we don't have tissue that's moving around, and we have the prosthesis that can be cleaned a lot better. And we can see now there's really no plaque or calculus or any kind of buildup. So this is I flipped it on this one apparently. So this is the before on the right, and this is the after on the left. Do we have any questions especially with the difference between the two and any of the techniques or anything like that.
From the palate, or you can get synthetic grafts. Is that critical to harvest that on the palate?
So I will say, personally, with my results, I have done some of the like the alloderm, the fibro guide. I have used some of those, the synthetic. It's basically all collagen. It just works so much better from the patient's palate. And cases that it would be good to use are similar to this first case I showed. So this patient had, to begin with, had thick tissue and a thick band of keratinized tissue. So if a patient like this asked me, can we use synthetic instead? I would say, yeah, it's fine. But I always let them know that the best case scenario, if they don't want to go from the palate, it is from the palate. But then yeah, we can get good results with the synthetic material, but not if they don't have any thick tissue in the first place.
Okay.
It's always an option, but to be very honest, in my hands, in my experience, I've had like 50-50 results with the synthetic alloderm. So I always suggest the other way, just from taking it from the palate, just from my hands, it just works so much better, and my results are so much better. Okay, so I know we're running low on time, but I can quickly kind of show you guys a crown lengthening case. So this is, where we have invasion of biologic width. We have the margin of the crown sitting way too close to the bone. And a lot of these patients will come in with like pretty bad temporaries that don't fit properly, or it's like a permanent crown that keeps popping off. So I'll just quickly show the before and after. This is done very similarly to the osteosurgery. So I'm opening up the gums and taking down the bone here. So now we have a nice prosthesis there. So that's another case. And then I know we really don't have too much time, but I do have some of my sinus lift and GBR cases if you want me to quickly just kind of show some before and afters of those.
Doc, actually, I had a question about the crown lengthening.
Sure.
So, like, what would you do, like crown lengthening on like tooth number 15? I know sometimes
Um,
access is difficult, right? So that
Yeah,
would
that's it. No,
be
that's a good question. So this case I'll show you. Okay. So this one is a good case because the furcation is pretty apical. We have a long root trunk and we have sufficient tooth structure. Um, in some cases, if the bone was kind of already down to here, or like the furcation was sitting higher, as it is a lot of times in the maxilla, we can't always do that. So yeah, I'm not really doing a lot of crown lengthenings on maxillary teeth. Those end up being kind of extraction and implant. Um, in my experience, have I done it before? I have. Um, but sometimes what they'll have to do is get a furrowed crown as the restoration, and just has to make sure that they have really, really good hygiene in that furcal region.
okay. I had like cases that I get referred, so I'm just kind of questioning because sometimes the perio is just like not great on the patient. So I had a case that was referred to me. And there was some frication involvement, maybe like a class two frication. Is there
Mhm.
really anything you can do to help repair or kind of graft the area for those kind of cases?
A class two furcation, if the interproximal bone is high enough, we can bone graft and membrane that area and get some coverage. But if the interproximal bone is at that same level, then we're not going to get as much coverage. Like the interproximal bone is really the kind of the basis of where we can graft until. Um, you can only build with what's there. So like I was explaining before, like, the interproximal bone being like the tent poles, it's kind of like that.
Got it. Okay. And then this one is probably a very rare case.
Mhm.
I had a case that was referred to me for a tooth. She was having, she had seen a previous endo, and they had been working on the tooth for about 10 months. And she said she was on antibiotics for 10 months.
There's your orange hat. Yeah, Maddie, Jen. Where'd you find that?
Leanna, can you mute
Yeah.
your mic? Thank you. So I looked at the patient, and she was pointing to the area where the tooth, so it was like tooth number 10 that was extracted, that had been working on for 10 months, antibiotics for 10 months. And she was pointing to the edentulous site that she was still having pain. And then number 9 had like a previous root canal, which is totally fine. So
Mhm.
looking at the CT scan, I saw a bony defect, and when I palpated the area, she was jumping out of the chair. She had a lot of pain. So for something like that, I mean, would that be something that you would look at?
Oh yeah, definitely. A lot
Okay.
of the times, and I actually have this happens, especially when we're grafting areas. I had my own patient yesterday came in for a 1 or 2 week follow-up after an extraction, and some of the bone graft material had just kind of extruded out. Like I don't know what the patients are doing when they go home, but probably it's a patient that like kind of swished around, didn't really follow instructions, or I just kind of overgrafted the area. So sometimes you'll
So,
have those like
okay.
shards of bone kind of sticking out.
Mm-hmm.
Um, and like that's something, no, I would not have waited 10 months to see that patient. But if you palpate the area and there's something sticking out, I'll usually make an incision, and it's usually necrotic bone. It'll break right off with like a cotton
Okay.
pad.
Sure. Yeah. So here's the thing. She kept getting abscesses in the area. So when I
Oh,
was
it
in
could also be a
residency,
failed bone graft.
okay, okay, we had a I wasn't sure if it was possibly osteomyelitis. So I don't know if that's a case that
It
you would
could
handle.
be.
Yeah.
If you have those x-rays or anything, you can totally feel free to send those over
Yeah,
and
actually,
I
I had
can take a
referred the
look.
patient to see you. I think she was supposed to see you this month in April, but then I guess you had to cancel the day, right?
Oh yeah, because I think we only had 2 patients that
Ah,
day.
okay. So then hopefully
Yeah.
she'll come and see you next month. Yeah.
Yeah.
Okay.
Yeah. No, I'll definitely let you know.
Okay, thank you.
Hmm.
Yeah, I
Um,
think talking about Dr. Kwan is my patient. I think she had a history of having endo done on that tooth by some other endodontist for long periods of time. I think 10 months or 12 months. And then, then we ended up extracting the tooth, grafting it, and then she was getting a little abscess in that area. So I had referred to you
mhm.
because number 9 had an endo, and she was slightly sensitive on the apices of that tooth. So I was not sure whether the endo was 100%. And then you saw a CT on that, and yeah,
Yeah, number 9 was fine. All the tests on that tooth was normal. On the CT scan, number 9, the RCT looks perfect. There was nothing to do on that tooth, but there was definitely some sort of bony defect that I saw in the extraction site of number 10.
right, yes,
But the fact that she kept getting abscesses in the area is, again, maybe just like Dr. Mara said, the bone graft failed or is possibly osteomyelitis. So, yeah, I wasn't sure who I should refer that case to, but Dr. Maris just said she would take a look.
yeah. That
Yeah.
patient has had a history of some failed implants and slow healing. So yeah, there's definitely something going on systemically.
Yeah, right.
Yeah.
Yeah, if like it's a diabetic patient, or any kind of, I mean, I've been seeing a little more osteoporosis patients. I've had a couple failures on those. But my guess is it's probably necrotic bone and it just needs to be opened and debrided.
Mhm.
I've had a couple cases like that too, especially on the mandible. Um, but yeah, it's probably something underlying that's causing it, but I think it just has to be opened up,
Yeah.
removed.
Well, thank you,
Yeah.
Dr. Mara. In the interest of time, we're gonna move on to the next presenter. But yeah, really appreciate the presentation. And maybe next time you can continue with the other slide deck you were talking about next month.
Yeah, it's really just showing off my work.
No, that was great. I really enjoyed it. I
Appreciate it.
learned
Yes.
a lot. So thank you, Dr. Mera. And it's
Thank you.
also just a reminder for everyone to, to refer to her, and we have her as on our team of specialists. So next I
And I
want,
also do a lot of extractions, by the way. Sorry.
no, that's great.
I do like most of what I do in other offices is extraction. So if it's anything you guys don't feel comfortable with or anything like that, feel free to refer them over as well.
Actually, that's another question that I would have then. So, there was a patient with a failed root canal with a lot of bone resorption with communication with the sinus. I mean, that's something you can obviously just extract and repair, right? That should be easy, no problem for you.
Oh yeah,
Yeah. Okay.
bread and butter.
Great.
Yeah, no issues. Perfect. Thank you guys. Sorry for running over.
No
Thank you,
worries.
Dr.
Thanks,
Mara.
Dr. Mara. And then
Thank
Dr.
you.
Mara and I created a one pager of when to refer. So every office should have it near the doctor's computer. I see it there. So now we know kind of when to refer. We can refer to that as well.
Great. So I wanted all the new joiners, people who joined us in the last couple of months, to give just a 2-minute intro of yourself, a little bit about yourself, which office you're at, what you're looking to learn, what you like to do in dentistry a little bit, and maybe one fun fact. So we have a list here on the agenda. Dr. Huber, do you want to start first, and then Dr. Chaimov and Dr. Saraf next?
Hello? Yeah, hold on. Sorry. Why is it not? Can you hear me?
Yes, we can.
Hi. Sorry, I don't know why the camera's not working, but hi, Dr. Huber. I have been practicing for almost 27 years. I went to USC undergrad, University of Pacific Dental School. My father was a dentist. My brother's a dentist. I continue to work with my brother and myself. I worked at the, I believe it's Hillview office, and
Yes.
I believe they had me go into the Oxnard office on Friday. My favorite thing to do, actually, I enjoy root canals. Easy ones, of course, but I do enjoy doing a root canal. I also enjoy doing anterior composites on chipped teeth. Not so fond of doing extractions, though. Fun fact about me, 3 years ago, one of our dogs had 11 puppies, and I raised them all. And it is their birthday actually today. And they are 3 years old.
Oh, that's good.
Oh, nice. Welcome. Okay, Dr. Chaimov.
Thank you.
Hi, guys. First of all, I want to say thank you to the doctors who presented before me. I'm not sure how many presented before me because I got in a little bit late, but it was very informative. And I'm happy to hear that and know that we have such a great team. So my name is Dr. Eden Chaimov. I moved here from Israel 6 months ago. I'm a GP for 3 years. I graduated in USMF Moldova. I'm not sure if all of you are familiar with that. But it's a school in the Republic of Moldova, which is accredited in California. What I enjoy to do is a lot of endo. I did do a lot of endo cases in my 3 years. I would say my next milestone would be to get into more surgery, implants, maybe even sinus lifts because I like the challenges always. Um, and a fun fact about me is my wife is due any day now. She's listening to us and she's very excited that I'm a part of this team. And yeah, that's it. Looking forward to it.
All the best.
Great.
Congratulations.
Thank you.
Thank you.
Dr. Saraf, if you're here with us. Okay, we can just move on. Maybe Shirley can go through the list for everyone else.
Sure. Dr. Chella had to step out as well. Dr. Gani, are you in?
Yes, I'm here. Hi, I'm Dr. Ghani. I recently joined the Santa Monica office. I graduated from UCLA, and currently I'm just doing general dentistry and looking forward to get to know more of the team.
That's great. Thank you.
Welcome.
Dr. Q.
Hello.
Hi, Dr. Q.
Hi, how you doing?
Good, thanks. How are you?
Good, good. All right. So my name's Dr. Q. I graduated from Loma Linda. I'm board certified in oral implantology. Yeah, I mean, I'm very fond of extractions. So yeah, whatever extractions you have, I'm happy to do them also. I love doing immediate implants. I do sinus lifts. I do grafting. Um, And yeah, I mean, that's about it. I do IV sedation also. So if you have any very fearful patients, I definitely can accommodate those patients. And I also do PRF. So that really helps with the healing and just regeneration and all of that good stuff. That's about it.
All right. I think we're breaking up.
Thanks.
I'm breaking.
You're breaking up a little bit.
Sorry, yeah, I'm kind of driving through a little bit of a dead zone.
That's okay.
No worries. We broke up on the fun fact, so we can hear you now. I want to hear it.
Okay, can you hear me?
Yes.
Yeah. So, long story short, I do implantology, immediate implants. So one thing that I want to share is if you're going to extract a tooth, especially an anterior tooth, um, unless it's really hurting or it's really a problem, don't take it out. Let me take it out because I want to put an implant in at the same time, given that the bone structure is good enough and all of that, because we can really create more aesthetic, beautiful results when we do that. If we extract it, then wait 4 months, then come back, then place the implant, wait another 4 months, wait another 2 weeks to get the crown on there. It takes forever for the patient, and it takes forever for us, and it doesn't even lead to the results that we always want. But yeah, my list is basically implantology, surgery, and IV sedation and PRF.
Great, thank you.
Great.
Yeah, of course.
Next is Dr. Seth. Dr. Seth, are you with us? No.
And then there are two people on my phone. I'm not sure who they are, but if any of those are new joiners, you want to unmute and introduce yourself.
No.
Sounds good.
Right. Should we move on to Dr. Josh to give us some kind of presentation on IV sedation and extractions of wisdom teeth?
That'd be great.
Right. Are you guys able to see my screen?
We're able to see your screen now. Yes. Yes.
All right, 1 second. Get this out of my way here. All right. So for those that don't know me, I'm Dr. Josh or Helmstetter. I work at our River Park location. I do a little bit of everything, but primarily like to do IV and wisdom teeth. So I'll try to make this short and sweet. If you have any questions, just wait till the end and we can go over it unless I ask something. And yeah. What I want to talk about is just indications for third molar extractions, anatomy and assessment, case selection for you guys to do if you like doing extractions, case selection for me, and then when I refer, potential complications that can arise, post-op pain management, managing complications, and then a quick tidbit about moderate sedation and how sedation and thirds work at Clove, or at least at River Park location. So for third molar extractions, we're all pretty familiar with the indications. I mean, pericornitis, caries, periodontal disease, cyst formation. These are all we're all pretty familiar with. It's kind of knowing when or when not to take out an impacted molar and what are some reasons, and I'll go over that in a little bit. So, example, we all know when cysts are forming, like what's circled in red. Those are indications to get it out and get that cyst out. That's important to get those cysts out when you remove the tooth. The first thing I look at when I am evaluating a case is just the vital structures. Where's the sinus in relation to the apices of the roots, and where's the IAN? That's kind of me determining if I'm going to take on this case or if I'm going to refer it out. So for this instance, if you look at number 32, this case is comfortable for me. There's the IAN, the superior border of it is outlined in red. And then where I need to cut to is that green line. There's still a good 1-2 millimeters, but I'm usually not cutting all the way through that tooth. I'm cutting 3/4, 80% of the way, and then breaking it. So in my opinion, this is still relatively safe for the IAN. And then if I need to, I'll make going the wrong way. A third cut or a second cut to the furcation, which is still a good distance of that to the IAN. So that's how I'm determining if I'm taking on a case. One thing that we should all know if we are taking out thirds or when we are wanting to refer is when we should take a pano and rely on just a pano, or when we should take a CBCT. So I typically use the Rude's criteria to determine this. So that is just, I'll go over this in the next slide. But if you see any of these indications on your pano, then that's a good time to recommend to the patient that a CBCT would be the best thing for them to at least give the best indication if there's potential for nerve damage or delayed sensation returning. So what I'm looking for is darkening of the roots on the pano, as you can see in A, deflection of the roots where they curve like that. That means they're in close proximity. Doesn't mean there's going to be damage, but higher instance. Narrowing of the roots, dark and bifid roots, interruption of the white line. You can't see it. Now on a panel, everything's two-dimensional, so it could just be superimposition, but that's why taking the CBCT is important. And then diversion of the canal and narrowing of the canal. So these are all common sense, and if the patient denies the CT, then they just have to know their risks of moving forward with the procedure. So in terms of case selection, I mean, there's Winters versus Pell and Gregory's classifications of impaction. We'll go over both. We're all familiar with health history and what we kind of need to look out for when it comes to extracting teeth, but I'll show a brief slide. And then one thing I think that a lot of people don't necessarily know is how to determine if an impacted third needs to be extracted. So Winters is just talking about the angulation, distal angular, vertical, mesial angular, horizontal, inverted, and just those others. Most others are definitely needing to go to oral surgeon, and same with inverted. So these all of Winters classifications come at with different severity levels, and that's kind of where we get into the Pell and Gregor's classification system, which is talking about depth of impaction. As you can see, it's pretty even in terms of height with the adjacent second molars. The level B impaction is between the CEJ, the cusps of the third molar are between the CEJ of the second molar and the cusp tips. And then level C means the cusps of the third molar are apical to the CEJ. And then there's classes 1, 2, and 3, which are talking about anterior posterior impaction in terms of the ramus. So as you can see from the picture, class 3 is pretty much embedded in the ramus, whereas class 1, you can see all aspects of the tooth anterior to the ramus. So I kind of sit in the level B class 2 range most of the time. Occasionally I'll venture into the level C, but rarely into class 3. That is out of my comfort zone, and so that's when I tend to refer. Health history, we obviously know to look for diabetic patients if they're on blood thinners, smokers, osteoporosis, pregnancy, stuff like that. Obviously, when it comes to thirds, we're also assessing anxiety levels. If they are, and I'll get into this in the IV sedation, what to look for health history as far as patients to consider for moderate sedation. So let me ask you guys this. How do you determine if an impacted third needs to be extracted? For instance, this pano versus this pano. Actually, let's do this pano. Which ones would you take out in this case? Anyone?
I would take maybe the upper right if it's causing any problems.
Number 1 and 32.
Yeah. 1 and 32 for sure. 16, I wouldn't touch it. It's more risk than benefit to the patient. You're gonna have to remove a lot of bone to get that out. And the way I assess if 17 needs to come out is 1, if they're in pain, and 2, sticking a probe. Here, I'll go to this panel. See that green line here? If you are sticking a probe in the distal sulcus of the second molar and you drop down to that third molar, that's an obvious indication to take it out. But in this pano, number 17, the sulcus was intact. I was getting 3 millimeter pocket depths, no communication to that third molar. So I elected to just monitor that. And with where it's situated, when there's no communication, that means there's less chance for less and almost no chance of decay forming on that second molar. And chance of resorption doesn't look likely in this case either. But in this patient, I said, hey, if you're looking to get all 4 wisdom teeth out, I'd recommend you go see an oral surgeon. If not, I can take out 1 and 32 confidently, and then we can monitor the other 2. And the patient was fine with that. So these are just so you guys can be aware of some cases that I'm comfortable with. These are some cases that I've done. This case, I extracted 1, 17, and 32. 16 was left. This case, I did 1, 16, 32. This one is another case where you should get a CBCT if you look at the roots of 32. You kind of lose sight of that IN, and now they're superimposed, but still good to inform the patient. So here's another case where I took out all 4. Took out all 4 on this patient. All 4 on this one. Any questions so far while I'm going through these?
Yeah, Dr. Josh, are you placing bone grafts when you're taking out these third molars or collagen plug, or just leaving it?
I'm usually doing collagen plug. I would like to do PRF. I used to do PRF at my last office, and there was a lot of less pain, but I'm still not seeing as much any pain per se with collagen plug. But when I've done bone grafts in the past for third molars, the patients tend to have a little bit more post-operative discomfort. And as long as it's done conservatively, you'll see that bone fill in. And honestly, getting sutures to keep that bone in is time consuming and a hassle in itself. So I'm usually just doing collagen plugs. Yeah, I did this case 32 and said, actually, no, I did not do this case. Was one I put in here to tell you this is a case that I would refer. As you can see, the level 3 impaction into the ramus makes it challenging. Now, most likely those crowns are on the facial aspect of the second molars, but with CBCT you can evaluate. But also, if I needed to cut, which I would, the furcation down in here, very close in proximity to that IAN. So most likely an oral surgeon, if they're taking this out, which the patient was in pain, so they'd probably just do a coronectomy for this patient. So always important to talk about potential complications prior to third molar extractions. If there's any sign, I always say if there's a sinus exposure, I'll know day of unless I have a CBCT. And if there is, usually it heals within 2 weeks with the right protocol. If you're putting collagen plug in, that's basically the treatment for it. Unless it's greater than 5 millimeters or not healing after about 10 days, then it requires a pedicle flap or something, buccal fat pad going in, something more extensive. Every time when I see Rude's criteria or some more involved apices of roots with the IN, what I'll tell the patient where I need to cut to is not close to the nerve. So I don't expect any permanent damage to the nerve. What often happens when we're taking out wisdom teeth, or especially some in that close proximity to the IN, there will be a lot of inflammation in the area, and sometimes you may have delayed sensation returning. So what I tell the patient is, call me the next day if you don't have sensation back, or it's very minimal, and I'll prescribe you a Medrol dose pack or Decadron dose pack to help decrease that inflammation, and usually that comes back. Pain management. Talk about pain when day 4 is peak. Swelling that can occur. I usually treat, and I try not to do antibiotics unless I'm placing bone, just because of potential for bacterial resistance. And treating that infection later on is a little more challenging. So if I see signs of infection at the post-op, then I'll address it. And then talk to them about damage to adjacent teeth, potentially damage to adjacent structures, and dry socket. So for pain, I rarely prescribe Norco. I do 800 Motrin Q8H staggered with 500 to 650 Tylenol Q8H, and I haven't had anyone call saying they need more, but I've had people ask ahead of time before the procedure saying, hey, can I get some Norco? Infection's a 5% chance. I would just tell people that going into it, and then if you see signs of pus, irrigate really well, put them on antibiotics, and then if there's still signs at 2 weeks, then you may want to consider reflapping, irrigating really well, and another dose of antibiotics. Inflammation, sensation issues. I told you if they call the next day, then I'll send the steroid. Document and follow up persistently, and there's some tests you can do. If you ever get into that pickle, let me know. I'll help you out. But you want to do some cotton swab tests or explorer tip pricks and just compare to both sides and see if there's improvement. Dry socket, main thing, no straws, no smoking, no vigorous rinsing. It's when they have radiating pain and Motrin's not helping. Sometimes you need to block them, irrigate thoroughly, and place a collar plug. If the IN was exposed during procedure, put some eugenol on that collar plug or gel foam, and put in if it wasn't exposed. But if it was exposed, do not put the eugenol. Paresthesia, yeah, that's what I just discussed. Oral communication, talked about that a little bit before, but yeah, if you have that oral communication, you want to put them on analgesics, which you already do anyway. Antibiotics, as long as they're not allergic to penicillin, Augmentin is the preference. And then nasal decongestant spray twice daily for 3 to 5 days. You don't want to do more than 3 to 5 days though. Hemorrhage, if I have a lot of bleeding intra-op, I like to use gauze pressure. If that's not working, then bone wax is super cheap and helps stop the bleed. You just have to let it sit there for a bit. And then just obviously biting in gauze and tea bags afterwards. And then if they're bleeding beyond, profusely beyond 4-6 hours, then they should come back in before the end of the day. Last couple slides. What is moderate sedation? It's conscious sedation, twilight sedation. They're able to respond to verbal stimuli, depressed gag reflex and pain threshold. They have amnesia or don't remember the appointment. And airway is often unaffected. And I rarely use oxygen, but if I have to, it's O2 via nasal cannula, usually at 1 to 2 liters per minute. What drugs do I use? Midazolam or Versed, which is a benzodiazepine. Pretty comfortable sedation and anxiolysis, as well as the amnestic effects. Fentanyl helps with your analgesia. So, and so I use those two in combination. I will often use diphenhydramine as a third medication as well. If I get a severely anxious patient, a redhead, or patients on antidepressants or that smoke marijuana, just to get, they usually take a little bit more to get down under. So that usually helps me get to where I need to go. When should you bring in an anesthesiologist versus referring to myself or sounds like Dr. Q? If they have a complex medical history, especially pulmonary issues or severe heart issues, putting them in ASA class 3. Prior addicts, usually hard to get to a comfortable level with moderate sedation. Severe dental anxiety, I had a patient that I didn't get to do a consult. I can't remember if he was in pain or not. But when he sat down in the chair, he had 140 heart rate, and I gave him some meds and he just could not calm down. So those people aren't going to do well with moderate sedation. And then special needs, neuromuscular disorders, or prior failed attempts with moderate sedation. So make sure you're getting good background history on these patients before just sending them over for consults for moderate sedation. Things to remember about thirds and clove: proper coding, knowing when it's soft tissue versus partial bony versus complete bony. Soft tissue, there's no bone coverage, but it's under the soft tissue. Partial bony, less than half of the coronal portion is covered in bone, and then full bony is more than half of the crown or coronal portion is covered in bone. Knowing when to take CBCT versus Pano. Asking the patient if they'd like to be sedated or do it under local due to finances. IV fee at River Park is $795. The IV pre-op form, if they are coming here without a consult due to pain and emergency, make sure they sign that when they sign their treatment plan at your offices. That is just saying that they understand the conditions of not eating or drinking for 6 hours prior, having an escort, and making sure they're not pregnant if they're female or breastfeeding. Yeah, an opening discussion from you helps get the patient in the right set. I prefer to do IV consults because, like that one patient that came in, just getting comfortable with the staff, clinic, and environment helps them get at ease. And like I said, exceptions to consult are patients in pain, emergencies, and all office managers should have that pre-op sedation form. And then I can send these forms after, but this is the pre-op sedation form in the second page talking about the cancellation policy within 72 hours. This is a medication list I hand out to every patient, and I just highlight which medications I sent over so they understand how to take the medications. And then this is my post-op instructions I give to the patients. So if you guys have any questions about thirds, IV sedation, have a case that you're considering doing or sending over, just text me. That's my number, and I'm happy to answer.
Thanks, Dr. Josh. Really, really informative. I can say from personal experience that when I have a patient in the chair who's in pain and I'm not sure I can do the wisdom teeth, I literally call River Park the same day or have my OM do it. And Dr. Josh somehow finds a way to get him in most of the time. He's pretty busy, but if they're not in that day, they can be in within the next couple of days. So you can shoot him a picture of the pano, you could email the OM, but a lot of times these can be taken care of pretty quickly.
Thank you, Dr. Josh. Those are some great presentations.
Yeah, very nice. So we have a handout of all the specialists with their bios that the office managers should have. We'll also send it to you all after this presentation to everyone.
Okay.
So just so that everybody can get familiar with everybody and know, you can always call the offices where they're based to get in touch with the doctors as well. So we can move on to the next one.
Sounds good. Dr. Gilbert, did you want to talk about bone graft and collagen with extraction?
Yeah, I can piggyback off what I think it's been touched quite a bit tonight, but
Yeah.
yeah, so I mean, obviously when we're extracting teeth, I think we need to think about what the end result or what we're doing as like the restoration, if we're placing an implant or a bridge. Obviously, if you're doing a denture, you need bone to to support the alveolar ridge because the denture needs the alveolar ridge is for retention. Dr. Josh, he was saying that he places collagen plugs when he does third molars, which is great. I think not placing anything is beneath the standard of care. But yeah, placing bone graft when if we want to place implants later on, that's important. A lot of the times, I don't think the patients, they don't visualize it. So I always bring up a Google picture with a comparison photo of like bone graft versus no bone graft, and a picture is always worth 1,000 words. So that really sells it for the most part. And I think it's really beneficial for them to understand it's, what the bone graft is going to be doing for them long term.
I agree. I
Yeah.
I definitely agree. And I think patients understand it. I do think the majority of the time there's financial limitations. That's what's holding them back. But we have Cherry, we have Sunbit, we have Care Credit, we have all these things. I'd say 95% of the time you should be able to put bone graft in there. And the other 5% you can put collagen.
Yeah, for sure. I agree, doctors. Thank you, Dr. Gilbert. Bone graft is definitely necessary and above standard of care when we do extractions. Um, so just wanted to touch up upon Perio charts. We should do Perio charts on every new patient. Some of the insurance companies do require Perio charts to submit the authorizations to get the SRPs approved. Inlays and onlays, I encourage doctors to do inlays and onlays instead of fillings. They definitely are more stronger than fillings. If you need crown lengthening on some of the crowns that you do, please refer them to Dr. Mara, periodontist. She'll be happy to take care of our patients. On all new patients, I encourage everyone to do the iTero scan, touch up upon Invisalign, ask patients if there is something that they want to improve upon their smile. And yeah, Dr. Anish, Dr. Puri Senior, did you want to touch up upon anything?
Yeah, I had a quick thought about the Perio charts. Not only do you need it for authorizations, you need it for SRPs to get approved after the fact. And you also need to know if you need to refer to Dr. Mara, what's your baseline? Did your SRPs work? Does this patient need SRPs? Perio charting is very important. Is the tooth fractured based off Dr. Kwan's, lecture last month. There's just so much value to holding that perio probe. It needs to happen. I don't want to be doing perio charts based off x-rays. So I'm going to start sending back to the doctor which patients are not doing the perio charts for.
I think I will add to it that in our basic setup, I think we should have a perio probe in every office. So, I mean, it really helps you a better diagnostic plan and treatment plan. Sometimes visually looking at it does not give you the full picture. Just probing it really makes a big difference. So I think probing is so essential.
Yeah.
Yeah, we'll set that up. That's a good idea.
So make it easy for everybody rather than asking your assistant for a perio probe. I think if you have a probe handy, you will tend to use it more, regularly.
Yes, for sure. We'll make that change.
And Anish, you wanna do a clinical basis for inlays and onlays? Because I think if we elaborate on that a little bit more, people will probably have some questions.
You go ahead and talk about it. I've talked about it the last few meetings, but you can talk about it and then I'll add on it.
Generally speaking, like a full coverage crown or an inlay or an onlay is your clinical judgment, but as a clinical protocol, any existing filling or any restoration, a new restoration which involves 50% or more of the tooth, then you want to at least put an inlay in there. If it involves a cusp, if the cusp is undermined, you want to put an onlay or you want to do a full coverage crown. So those are the clinical protocols. And what material you use also really becomes very important. Zirconia, of course, is our go-to material for molars. You can do Emax or composite with ceramic fibers and inlays. For me, inlays composite really with ceramic fibers works really well, but it's your personal choice. So yeah, that's my basis of doing diagnosing inlays, onlays, and crowns. So anything 50% or more should have those indirect restorations, because doing a beautiful composite or chair side composite, which is large with large contacts, is, everybody knows, it's one of the harder things to do in dentistry. So to have a great contact, great anatomy, and and if it fails, then it's just not a good thing for the patient and for the office. So yeah, I would encourage everybody to kind of look at it from that point of view. Yeah.
I agree. I mean, I think if you can't create a amazing contact and food's gonna get trapped, or it's a touch contact and the lingual is open, or vice versa, do an inlay. Let the lab design it. Get that broad contact. We want things to last a long time.
Another thing, going away from it, use isolite, for retraction and isolation, doing composites and all. There are several other things we have in every office. I would encourage everybody to start using that, or if you don't have it, put that request, because I feel like you do a better dentistry. And even, you sometimes if your assistant is busy, you don't really, you can still go ahead and proceed with it. So Anish, maybe we can look into that and getting isolite or something.
A lot of the offices already have it.
Okay.
So actually 75% of the
Wanna go
offices
potty?
have it.
Want to go potty? Okay.
And that should be, yeah, and looking at the medical history, dental history, a lot of times the dental history, I'm hoping everybody looks at the dental history, what the patient puts in, and they would put that in black and white, what their needs are, or what they're hoping for you to address. A lot of times, if you look at it, that would be an opening point for conversation with the patient, and it leads to better satisfied patient, diagnosis and treatment.
Yeah, perfect.
Sounds great. Just a couple notes. Anish, anything else you want to talk about?
No, all good.
Okay, I really appreciate everybody's time today.
Anybody wants to have
Any questions anybody has? I had a couple of points I wanted to make before. Okay, great. I mean, from my side, we're always looking for great team members to join our team. We're a growing organization, as you've all seen us grow even the last 6 months. And the best referrals come from our existing team. So if you have any great other doctors, assistants, front staff, anybody you think, or even hygienists who you think should join our team, please send them my way. We've got an amazing team that kind of filters through those, and if they're referred to us, then they get priority. Basically, the best hires are always those internal. We feel everybody on this team has gone through a rigorous screening, and they're part of the Clove culture that we're trying to set of excellence, teamwork, and growth. You know, my priority for everyone is every team member from top to bottom is always growing clinically and just overall as individuals. So I appreciate everybody taking the time today. And Shujal, any other points you wanted to mention to the clinical team?
No, not really. Thanks everyone for joining this meeting, and yeah, that's about it.
Sounds great.
So we do this in a month or so?
Yeah, we do it the last Wednesday of
The
every month.
last Wednesday of the month.
Okay.
And we'll send a recording after this. And Shujal, you'll send the notes to the dentist email.
Yeah.
Okay, perfect. Thank you, everyone.
Thank you all.
Thank you all.
Have a good evening.
Bye, guys. Thank you.
Thank you.
Bye.